Hello, good morning, good afternoon, and good evening to all the speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to the ACNS webinars. So the speaker for the first session today is our honorable guest from Italy, Professor Gianantonio Sprenna. Professor Sprenna is the Director of Neurosurgery Unit at the IRCCS Fontecchio Policlinico, San Matteo, Italy. He is the co-founder of the world-renowned startup, The Upsurge, who has revolutionized the stimulation practice in neurosurgery. He is an author of several book chapters and articles in the leading neurosurgery journals. We're extremely honored to have him today at our webinars, and he will be talking about the surgery for insular tumors, tactical nuisance to avoid risk and extend resection. The speaker for the second session of today is our honorable guest from Hungary, Professor Ethan Hudak. Professor Hudak is a visiting professor at the CINRE Hospital, Slovakia, Alexander Clinic Hospitals, Ukraine, and Clinical Emergency Hospital Lviv in Ukraine. He was the former chief of endovascular neurosurgery at the Hungarian Defense Forces Medical Center at the Budapest Department of Endovascular Neurosurgery in Hungary. He is a well-renowned faculty in endovascular neurosurgery who has pioneered the novel technique of embolization for AVMs. And we are extremely honored to have him today at our webinars. And today he will be talking about the breakthrough in endovascular neurosurgery, which combined transarterial and transvenous embolization for AVMs. So the chair for the first session of today is our honorable faculty from India, Professor Suresh Dugani. Professor Dugani is a consultant neurosurgeon at the International Neuroscience Center, Shikuba Hospital in Hubli, Karnataka, India. He was a former fellow in the Fujita Health University in Japan. He also experienced neurosurgery at several referral centers in the world, such as in United Kingdom, Amsterdam, and Vancouver. He is a very experienced neurosurgeon who has accomplished the feat of performing over 18,000 surgical procedures. He's an invited faculty to several workshops and conferences around the world, and we're extremely honored and grateful to have him for accepting our invitation to chair the first session of today's webinars. On behalf of the Educational Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers and the chairs and the audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we're extremely thankful to Professor Xu Bin for broadcasting the webinar on the WeChat channel. Dr. Liu Bunsing from Malaysia is my co-host today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Dugani.
Thank you, Mr. Bednock. Indeed, it's a pleasure and honor to be with you this nice day and participate in wonderful scientific exchange. First speaker presenting is Professor Gianantonio Sprenna. Just now you heard his introduction from Italy, well-accomplished and well-known neurosurgeon. And I think he'll be talking on the most important topic in neurosurgery today, and even in the past, probably in the future also, the management of Sylvian fissure and insular region tumors and the management of these lesions and complication avoidance and the ways of managing, which is a very, very intriguing problem for all the neurosurgeons all over the world. And we are waiting to hear from him and learn from him. And this information, we can keep passing it on to our students and our patients for the betterment of their lives. We're very glad to invite you, Professor Gianantonio Sprenna, and stage is all yours. Please go ahead and start the presentation. Thank you.
Thank you very much, Professor Suresh, and the organizing committee. For me, it's a big honor to have been invited. And as already said, this topic is it's a topic which interests many parts of neurosurgery, and have been interested in many parts of neurosurgery for many years. I'll try to go through basilar concepts, but step by step also to go through surgery and I understand how to make it faster, safer, and at the end to have larger resection. We all know that the main difficulty in this surgery is the fact that the insula is completely hidden into the brain. I mean, it's completely covered by the frontal and temporal operculum. Well, the first concept is that at the end, I would say 2/3 of the insula are rather covered by the frontal operculum rather than the temporal. So this is the first concept to understand. So when you get there, you have to move the frontal operculum away. Very quickly, from a cytological point of view, there are at least 3 different cells composing this cortex, which is an anterior part, which is an agranular zone made of allocortex, related to autonomic, olfactory, and emotional function. The central part is rather composed by this granular zone, and it's related to cognitive function, memory, and language. Whereas the most posterior part is made of neocortex and granular cells, granular cells, and is related to function of viscerosensitive, somatosensitive, and gustatory cells. When we talk about surgical anatomy, it's extremely important to understand anatomy from a 3D point of view, and to understand that we must have cardinal points when we operate on this tumor. Because if it's true that when you open the sylvian fissure, you have a lot of references, but it's also true that when you are inside the insula, you have anything you can rely on to orientate into the insula. So we know that the insular cortex here, this is a coronal cut of the left insula, cover the extreme capsule, the caustrum, the external capsule, the putamen, the pallidum, and then the internal capsule. Just pay attention to the fact that you have the most superior part, which is the superior limital sulcus, and the inferior part, which is called inferior limiting sulcus. These are very important, and I will show you why step by step. If we isolate the insula, like in this beautiful specimen, you see how the insula is divided in 2 by this long long fissure called central sulcus. And you have in front of this sulcus, you have 3 short gyri, and in the back here, you have 2 long gyri. This sulcus has an upper end and a lower end, and these are very important. In the upper end, which terminates, of course, in the superior circular sulcus here, this upper end of the sulcus here is the point where insula is much closer to the internal capsule and the corona radiata. So this is very important to understand this point. On the contrary, in the lower part of the central sulcus here, you are at the beginning of the limen insulae. The limen insulae from Latin is the limit of the insula, and it's a very important point, as I will show you soon. To complicate the matter, the insula itself is completely embedded in an intricate crossover of fibers. The first and the most actual, I would say, bunch of fibers is the superior longitudinal fascicles. It's very important to understand that the SLF and this most posterior part, the arcuate fasciculus, encircle the insula. So like a collar around the insula. And here in this, down here in this coronal cut, you see the position of the SLF. The SLF encircled, and this, if you see here, is just at the end of the superior sulcus. So if you penetrate the cortex of the insula in this point, you are inside this white matter, which is the SLF. Then the capsule and the corona radiata is much deeper. This is a beautiful image here that explains exactly what I'm telling you. You see how the SLF encircle the insula, and you see how the position is just beneath the cortex here. So at the same time, when you terminate the sulcus, for example, the inferior frontal sulcus, you are just inside this white matter, which is the SLF. Sorry. Another extremely important point is of white fiber is the CST, so the cortical spinal tract. The cortical spinal tract represents the most medial and posterior part of the insula. I would say again that you should not fear the position of the internal capsule at this point, but once again at this higher point, because at this point I tell you that before getting into the cortical spinal tract, the capsule, you have all the nuclei, okay, all the basal ganglia. So it's quite difficult to get into the internal capsule. Rather, getting here inside the corona radiata here, it's much easier. So it's much dangerous. And this is, again, this beautiful preparation here. You see how the CST is medial to where we were when talking about SLF. SLF was here, more medial, more deep. There is the CST and the corona radiata. And the other very famous bunch of fibers is the IFOF, the inferior fronto-occipital fasciculus. As you can see, this run at the bottom of the insula. Okay, so it's very important to understand this. And you know very well that IFOF is implicated in semantic processing. Okay, and to understand where it is, again, you have to understand where is the Limen insulae. So if you imagine that Limen insulae is here, you have this bunch of fiber passing into the temporal stem. I will show you soon what is the temporal stem. Temporal stem is a structure of white matter, which is medial and posterior to this Limen insulae. And in this temporal stem, you can see very well here, that this is the temporal stem in a sagittal projection. This is the temporal stem in a coronal cut. In the temporal stem, you have the fronto-occipital fasciculus, and as I just said you, it is the lower part of the inferior sulcus at the end of the central insular sulcus. And the uncinate fasciculus is also here, the IFOF, the anterior commissure, and optical radiation as well. What is interesting, and it has been demonstrated by some authors in the last year, is that deep perforators coming from the lateral lenticulostriated arteries that you can see here are just medial to the IFOF. So there are some others that advise that when the patient is in an awake condition during mapping, if you eliminate the most superficial part of tumors and then you get into the insula and in the inferior pole, you can stimulate, and if you have some semantic errors, you can anticipate the position of the lenticulostriate angle. This is a strategy. I also will show you other strategy to not damage these arteries. Of course, the most part of our attention is dedicated to vascularization of the insula, which is very complex. We all know what is the content of the Sylvian fissure, of course, are the vessels of and the bifurcation of M1. This is the most superficial part here of the middle cerebral artery. But of course, again, what we fear the most is the presence of perforator here, which pass through the anterior perforated substance, which is very deep, and then this vessel penetrate the anterior perforator and pass deep into the insula. we can damage this, and we do not do this when we do surgery. Otherwise, very severe deficits can happen. I just turned top down the former image to show you in surgical position. So you see here your M1. We have in this photo the frontal operculum has been resected, but I just put in this position to show that the deeper arteries, so the perforators, follow almost the same direction compared to the vessels of the sylvian fissure. This is important because in your mind you have to have always a three-dimensional vision and of the organization of the vessel in order to spare it. This is quite a bit messy, but I show you how to read it. You see here, this is from right side. This is the optic nerve, right optic nerve. You see the chiasm here, carotid artery. You see here M1 turning into the sylvian fissure. You see bifurcation here. Okay, why this photo? Because here the insula has been removed, and you see very well the perforators, so the lateral ventricular striate arteries that enters the anterior perforated substance. Another interesting way to locate the anterior perforated substance is the offertory groove. As you maybe remember, the offertory groove, when it gets at the base of the frontal lobe, it divides in two. Well, in that division, there is the anterior perforated substance. Again, the complex vasculature of the insula is mainly based on the division in perforators. Luckily, I would say, not all perforators are dangerous. The most dangerous are, as you can see here, 2 and 3, medial and lateral lenticulostriates. These one here are just short perforators. They are dedicated to cortex of the insula, but I mean, you remove the insula, so that's not a problem. But again, at the top of the insula, very close to the superior circular sulcus, there are some long perforators, which are very important because they can terminate into the corona radiata again. So pay attention. This is a beautiful image. Here you have a sketch of the left insula. You have here a right insula that has been almost all removed. And you see exactly what I was telling you, this long one here that penetrates and gets to the corona radiata. It's important to understand that if you draw this virtual line here, you can separate the territory of the long insular artery and other perforators like lenticulostriate from other perforators coming from M4, for example. And this is not just a study matter, but it's very important because in post-operative, when you have some problems, and you do not, I'm talking about deficits, and you do not understand why, if you perform diffusion weighted imaging, you can see different type of strokes, little strokes. If strokes are B or C, they depend upon long insular artery or lateral striate artery. Otherwise, if you see stroke here, most probably that problem were with M4. And this is exactly what I'm telling you. Look at this, and this are dependence of LIA or LSA. Very quickly, the connexionism of insula is very, very high. It's about 50 years that we have been knowing that insula surgery is related to very few cognitive alteration postoperatively, but rather we fear motor deficit. And they demonstrated, these two different groups, that insula at the end is extremely connected with the other side. And so that's why insula resection can be compensated by the point of view of cognitive function. Let's go to the pathology afflicting the insula. mainly gliomas. We all know that. And you should know that 10% of all high-grade gliomas are located in insula. Similarly, for low-grade gliomas, it's higher rate, and it gets to 30%. And what is interestingly, specifically for low-grade glioma, is that the low-grade glioma in this location seem to have a little bit better outcome. And this is related to the fact that the percentage of glioma with triple positive oligodendroglioma profile, which is IDH mutation, 1P, 1Q, LOH, and TP53 non-mutated, it's higher. So somehow in this location, low-grade gliomas with a good outcome are higher percentage. And this is important to know because this, I would say, mandate us to have an aggressive resective behavior. The typical patient with specifically with a low-grade glioma and dislocated is a young, has a problem with seizure, so seizure at onset, and very frequently these are large volume tumor. So another point is that especially when the tumor is in the non-dominant side, this patient could have very subtle neuropsychological impairment. I found, for example, patient with depression or patient with really apathic. At the end, they have change in their mood. Given that we're talking about surgery, the first question to pose is always the same. Does this surgery make the difference? Yes, that has been demonstrated by several authors, and the resection, the extent of resection is strongly related to the final outcome and to survival. So this is a very interesting point, because due to the complexity of the surgery, if we decide to do an aggressive surgery, we can do that for sure, but we have to understand that we have to decide to operate and to resect at least 90% of the tumor. Otherwise, this does not change the future of the patient life. And this is correct for low-grade gliomas, but also for high-grade. So this applies for both. When we talk about surgical strategies, well, of course, we can decide to embrace different strategy in this surgery, but it's also clear that insula is an eloquent region itself, and not only from a point of view of functioning, it's also for vessels. So we have to use all our concept in functional neurological surgery. That is, we have to balance an aggressive resection with optimal neurological outcome and quality of life. And this applies to all glioma surgery. And we have to give our patient a very good outcome. Otherwise, these are patients that will eventually not undergo chemo or radiotherapy, and this translates to shorter survival. And this has been published many times. But at the same time, differently from other gliomas in other locations, these gliomas needs the surgeon to master microsurgery, vascular manipulation, subbile dissection. Otherwise, this surgery can become a real nightmare. Surgery has dramatically changed along the last 30 years, and that has been demonstrated by large volume centers, and where they published series with definitive deficits like 4 or 6%. This is very, very good outcomes. And but also most recently from Barrow, Nader Sanai just published this paper where he demonstrated that also 10–11% of good outcome is attainable, and it's acceptable, I would say, due to the difficulty of this surgery. If we talk about outcomes, once again, the most feared bad outcome is related to motor deficits. Okay, why? Because it's very rare to see a patient with permanent language disturbance, because these are very frequently transient, and this is not a case because, as I showed you, the complexity and the connexionism of the insula make this deficit really compensable. Whereas when you have an hemiplegia, unfortunately, it's more like a stroke, and this is rarely recoverable. But one of the most difficult part of understanding the anatomy and depicting the strategy of surgical removal of a glioma is the fact that there is not a tumor which resembles another. There is many variables, there are a very high complexity and variability. And I'm talking about location, of course, which is not just insula, but any millimeters make the difference inside the insula. But also the size change a lot, and more the texture of the tumor and the infiltration pattern. Is it a tumor which is more compact, which is bulky, or a tumor which is more infiltrating? And also, when we decide to go for surgery, it's very important to understand on neuroimaging the biology of the tumor. Is it slow growing? Is it high grade? This is very important. One of the key to understand insular glioma is to deep analyze the neuroimaging. I'm not just talking about advanced like DTI fiber tracking or functional MRI or new, I would say, new technique to reconstruct the organization of functional around the tumor. I'm talking about the basic anatomical imaging, which give us a lot of information. And this is why sometimes in the past we segmented and reconstructed in a 3D fashion different tumors, because this gave us the possibility to really and better understand the anatomy of these tumors. One of the most important concepts I try to pass today is that when you go in the operating room to resect such a tumor, you have to have reconstructed in your mind a 3D mental imagery of this tumor. Why? Because around the tumor there are such plenty of fundamental vital structure that there is no navigation, no other stuff that can help you. The only thing is to know the anatomy, but also to understand the anatomy of that patient, of that three-dimensional organization of that tumor and that structure. In this way, you can orientate yourself and your instruments. This is just some example to give you some hints in exploiting the basic imaging. You see here, this is a classical tumor. You see how it's quite easy to understand the position of perforators here. And it is nice to know before surgery. Why? Because in your mind, you know that you can prevent the position. I will show you soon how. Another thing is to, as I told you, variability is very large, okay? So there is a big, huge difference between one and another tumor. At the first sight, these two tumors looks quite similar, but the differences are very, very deep. You can notice here this quite sharp cut of this tumor. What does it mean? It means that this tumor has not passed the limit of of the deep nuclei. So this means that this tumor is limited to the insula and white matter of the insula. In this case, and how can I say this? Because this is the posterior leg of the internal capsule, and this is the putamen. If you look here, you see the internal capsule, you do not see the putamen. So the tumor has infiltrated the putamen and it's completely infiltrating the internal capsule. These tumors are completely different and the danger are completely different too. As maybe you remember, I just showed you three-dimensional segmentation of two tumors. As you can see here, if you do that, I would say, exercise, this training by segmenting tumors, you see very well here how what I just told you is demonstrated. You have here your tumor, you have here the plan of the perforators, and then the internal capsule. Here, there is just a mashup of everything, and the risks are very high. Not only the risk, I would also say that whether you give patient a bad outcome or whether you can just remove, I would say, half of the tumor. So this is, on the left, this is a very bad case. But today, do we have, a part of analyzing images, etc., do we have scales, score? How can we predict the outcome of a patient? And also, how when we are counseling a patient, can I tell a patient, okay, you are very high risk or you are a good candidate? Can we say something with scientific validity? Well, we all know that Berger and Sanai in San Francisco just published this classification based on the differentiation of 4 quadrants in the insula. And basically, they created a classification of topography, okay? And they demonstrated that based on this classification, there were a good correlation with morbidity and extent of resection. Unfortunately, this is just topographic classification. So we can say that could be not enough in this surgery. I'd like to cite this Kawaguchi paper who tackled the problem by analyzing also other factors, which are more related to morphology, to biology. For example, you can see that inside this score, they put the margins. Are they smooth or infiltrating? The fact that the tumor contrast, uptake contrast, or if there is infiltration of the anterior perforated substance. Or, for example, again, if you remember what I just said at the beginning, is there infiltration of this point, which is the superior extremity of the central insular suit? So all this, with this criteria, they also showed correlation with the outcome and the resectability. I think that, and this is what we are working on, I think that we should put together all this classification, trying to create a multimodal and a score in order to help a physician. But again, we are going to the operating room, so we have to have clear in mind how to have the larger resection possible and to give patient best outcome. One of the cornerstones of this surgery, of course, microsurgery, but is the use of large neurophysiological monitoring and mapping. And that's why in my routine I use in all cases, despite left, right, I don't understand. I don't mind about that, the laterality. Always use transcranial MEP and SCP, cortical strip, continuous MEPs, of course, EMG and EEG. And this is the basic setting in order to have a continuous monitoring of the CST integrity, and also very important to have a warning of vascular injuries. And for example, in cases like that, this is a large tumor. You see on the right of the screen the resection that we can consider complete. This patient, I operated on a sleep surgery with a large, extensive intraoperative mapping, and I also did a trans-Sylvian approach, because another issue is to go through the operculi or through the Sylvian fissure. In these cases, it's very important again to go for the stimulation of the corona radiata and the internal capsule here in the upper part, and I will show you how. So awake surgery has a role. Yes, it has. We all know that there are centers that do awake surgery for every single insula case. This is not my my choice. I prefer to use awake when the patient has either infiltration of language tracts in the dominant hemisphere, or if the tumor infiltrates the opercula, the frontal operculum, both right or left side. So this is for me an indication. But in case where the tumor are just limited to insula, so purely insular, frankly, the awake surgery is quite useless. This is surgery to do with IOM and a microsurgical technique. Because as I told you, stimulating insula do not give you more information about functions. Again, this is a patient that operated in awake surgery because it was very large and the vicinity to the SLF or the IFOF was very, very close. So I decided, but I did not perform a transopercular because I prefer to have a healthy brain healthy. And so I did it in a transilium, and you see here in sagittal how the operculum are very good. And this is a case where transoperculum is good. In this case, I remove completely the operculum before addressing the tumor inside the insula. This is also the same another case. Some nuances. When you position the patient, one of the cornerstone is to put the head almost parallel, the midline of the head parallel to the floor. Why? Because it's extremely important to have the M1 that you see here in a sort of vertical position, because this greatly help you in orienting the position of the perforators and also to give you a sort of reference for the deep planes. Okay, so again, this is an MRI of insular glioma, and you see here the MCA. Okay, this is put the image in a surgical position. What happens is that when you have the patient with the head flat like that, you know that here is the M1 that come from depth to the surface, and you know where are the perforators. So you have you can calculate in your mind the position of the perforators and the deepest plane, and you can see here in coronal. But to understand better, just go step by step. The first part in this large tumor is to open the sylvian fissure and to decompress the tumor. What does it mean? You have to remove the most superficial part. You see in this sketch here is the left, is the right, the red image here. And this is important because give you a decompression of the muscle. These are large tumor. This is complex to manage. Once you have resected this, you have more space. And this space, the other part to get addressed is the most anterior part. Why? Because in this way, you go and separate M1 that you see here. You see how vertical it is. In this moment, you see the perforators going to the APS, anterior perforated substance. I show you again. Just look where my arrow is, my pointer is. You see how perforators comes out from M1 and go in this direction, which is the anterior perforated substance. And as I told you at the beginning, perforators go like that. They follow the direction of the M2, M3, okay? But it's important because when you have this point here, you know that all which is here can be removed very safely. So you can remove all the anterior insula without any problem. Again, this is the image I put at the beginning, and you see here the perforators. That is exactly the same that you just saw inside the operating room, going to the anterior perforating and inside the insula in the depth. Of course, the most feared part is the central part of the tumor. Why? Because here we do not have any other references. I mean, we are inside the brain, inside the insula, we can lose ourselves. But it's not true at the end. In this phase, what is again very important, and that's why I just started my presentation with this, it would recognize the superior circular sulcus. This is extremely important because when you have this limit here, and when you have pointed out the position, as I show you, the position of perforators where they get in, then in your mind, you can draw a line between this point, and this gives you, luckily, at least I would say, a representation of the deepest part of the tumor. Otherwise, you do not have any other references. So remember this because this will save your life, that's that of the patient. In this, in this footage here, you see you have removed the most part of the tumor, and we see here the tumor on the right and this white matter here. So here we had our perforators. Here, this is the frontal operculum, and here we see the white matter. Again, you see that we are quite deep in the brain. We are beneath the frontal operculum that has been without retractors, of course, but it has been retracted with aspiration here, and you find this. In that way, you know that all this you can remove, and this point here will be your, which is this point here in coronal, give you the point where you have to stop. In that phase, you can stimulate IFOF here if you are on the left side, or SLF here if you are on the left side again. Whereas the CST is much posterior. So do not search for the CST here. CST is in this direction. And be smart. If the cortical strip is here, of course the CST is in that direction. So don't be fooled by looking for CST whatever. It's just in this direction. The last part, I would say the baddest part, the worst part, sorry, is the most posterior, because it's completely covered by the parietal operculum. So unfortunately, you can just retract and aspirate. But sometimes, even in this case, beautiful case, you can really, left behind something. Some other published the parietal operculum approach to resect this. But this is another issue. I think that there are also some intraoperative tricks that I like to talk about. Please do not operate this patient with hypotension. If the patient is hypertensive, I'm not telling you to operate at 160, but if you operate in hypotension, all these perforators, all these tiny vessels, all the manipulation will do on these tiny vessels, they can translate in a vasospasm. So very good arterial pressure. And if something changed with your potential in your intraoperative monitoring, stop, increase the arterial blood pressure, just wait. And if you think that something's going wrong, first things to vasospasm, so papaverine, and wait. Of course, sometimes you can have some major stroke. In that case, your evoked potential will not reverse. Another point, which is very practical, but it's very important, when you're operating on insula, I show you just very high magnification. But if you remember, when you have to have your three-dimensional mental imagery, you have to decrease, increase continually, or I'm not saying every 3 seconds, but you have to have your image, so you decrease the magnification, then you come back to the particular, because in that way you have the 3D mental imagery of the tumor. What can we expect postoperatively? Many patients have a decline of their postoperative status, but they recover very good. And remember that IOM and mapping can help in predict, because if the patient is good at the end of this the resection, and the day after or the evening he has an hemiparesis, he will recover. Okay. Another point is if you do not understand why the patient has some deficit postoperatively, remember, as I do every day, to perform postoperative MRI. As you can see here in the DW, so in diffusion weighting, you see these black spots. These are strokes, okay? And this explains you why the patient has had some problem. To conclude, deep knowledge of the anatomy and physiology is of paramount importance. Multi-professional team, it's important. And neuroradiology, you have to have a deep knowledge of the image of the patient. Of course, surgical skills, this is not a secret. But also, I think that you cannot go into the insula as your first surgery. So when you do your temporal lobectomy, you can have your first journey into the insula, look at the insula from many different perspectives, from above, or when you resect the frontal lobe, just have a look to the insula. So get in touch with the insula step by step, not just one day another, as in this case that you remove a tumor which is not insular, but you can understand the anatomy of the anterior insula. So I just thank you very much for your attention, and I'm here to answer your eventual questions. Thank you very much.
Thank you so much for your presentation. Professor Dugani?
Spena. It was a wonderful talk with the emphasis starting with the anatomy, physiology, and the approaches and the accesses. Definitely you have made the topic very easy for us to understand and follow it up and show with the various 3D reconstructive images. And the most important, as you mentioned very nicely, ultimately it is the post-operative problems what we face in these patients is due to the vascular involvement, and there are devastating neurological deficits. Thank you very much for the excellent presentation. And as we know, for the first time, the area of the brain is always intrigued from olden times to present times, and it's going to be in the future also, as I mentioned earlier. That's why first time when Professor Jesse Ryle in 1809 identified this. He called insula. It means it's a separate island surrounded by the various important mountains like temporal lobe, parietal lobe, and occipital lobe. And they called many anatomists and neuroscientists, they call this particular part of the brain with a specific and specialized, very important function. One part of the brain with a very important functions as the fifth lobe of the brain. The fifth lobe of the brain after temporal, parietal, occipital, and these important lobes. And probably this, as you very well mentioned in the anatomy, the one part of the brain controls not only the motor functions, the thought process, psyche, autonomic, and the thought process with its various connections through all over the brain, ipsilateral and contralateral, contributes extensively for the functioning of the brain. And this problem probably intrigues many of us as neurosurgeons while we were operating on these regions. You brought out very, very nicely and explained the things, made it very simple and easy. I thought you brought out you mentioned all the problems. A few things I thought I will ask your opinion on the management of these lesions. Do you do angiogram, high value angiogram like 128 slice or 256 slice, either a CT angio or a DSA, before you go ahead with the surgical intervention in these cases. Number one, functional MRI in these patients, because of on the left side, does it help more? And in a large lesions, preoperatively, before you go ahead with I'm asking many questions, or if you want, I can ask one by one. Is it okay?
Oh, it's okay. It's okay.
Yeah. Do you do the preoperative biopsy of these lesions and assess the grades before surgery? And how helpful this Bregman-Senai division and classification in managing these lesions? Because these lesions, when they grow, they don't respect or honor the locality, what they divided as zone 1, zone 2, zone 3, and zone 4. They don't respect any of these zones. So for us on MRI or on imaging, it becomes very difficult to locate these lesions. What is your take on these points, what I mentioned to you, Professor Spena?
Yeah, if allow me, I will start with the last question.
Yeah. Thank you.
And I think it's very, very interesting because if you remember when I was talking about Berger-Senai classification, I think that it's merely topographic. But as you brilliantly said, these tumors are rarely limited to one sector or the other. And so it's, in my opinion, it's my humble opinion, unfortunately, the Berger-Senai is a very limited classification. And that's why I think that in the future we have to have our efforts to put together different classification and create another one. Because exactly as you point out, also the biology of the tumor, is it a slow growing? Is it a high speed growing? And this makes the difference, because sometimes there are some low-grade glioma, which I know that they are not limited, but at least at the level of the surgery, they are quite smooth. And this helps a lot. There are also tumors that are like clouds, okay, and there is no bulky, so it's extremely difficult to resect. So at the end, I think that we do not use to do biopsy earlier, because with the new perfusion, spectroscopy, DVI, etc., we have very good diagnosis, neuroimaging diagnosis. So rather, if it is a large, huge glioblastoma, which is frontotemporal insular with a patient who is, for example, hemiparetic, etc., and the tumor is deep, well, in that case, many times we talk to the patient very clearly, because the risks are very high. The patient has a very dismal prognosis. So frankly, we have to tell ourselves and to the patient that maybe it's maybe we can do just a lobectomy, for example, temporal lobectomy for the sake of pressure in the brain, but go through the insula, taking risk, very high risk, to eliminate a glioblastoma, which is deep. Frankly, this is not a good strategy. For the fMRI in the dominant hemisphere, we used to do, but I would say seldomly, because either we decide to do awake surgery, and in that case, fMRI can be just something more. But if you have the patient awake and you stimulate, you have everything you need in that moment. And the other point regarding the angiography, no, we do not do that. We do rather a very thin MRI section in T2, where you can really find your tiny vessels as good as an angiography. So we are okay with that.
Yeah, thank you, Professor Senna. There are two questions from our participant colleagues, neurosurgeons. One, Professor Harshad Parekh is a very senior, accomplished neurosurgeon from Mumbai, India. His question is that, how many cases of GBMs, percentage-wise, you see them in the insular cortex, and what is the long-term outcome of these cases? Number one. And do you operate these? The second question he's asked: do you do these cases in awake craniotomy in these cases? What is your
you mean awake craniotomy for the high grade?
High grade.
Okay.
Yes.
First, high grade glioblastoma in the insula as a location I see far less compared to low grade. Okay, so yeah, it's not routinely that I see a glioblastoma in the insula, but I would say, as I just told you, maybe I suffer a bias because the large and huge lesion in that region that are supposed to be high-grade gliomas, I mean glioblastoma, sometimes we do not do radical surgery. So we do radical surgery if it is a glioblastoma inside the insula, so something which is limited to the insula, which does not infiltrate the putamen, which does not infiltrate the capsula. So we go into the insula because insular surgery is safe. But if the extension of the tumor is extremely more deep, no, it's very, very, very rare. Rather, we do a biopsy. And I just want to say that glioblastoma is a worse prognosis in the insula as in the occipital lobe. I mean, there is not difference. Of course, the problem with the insula is it's very close to the ventricles. So the presence of a glioblastoma, which is abutting to the ventricle, so to the ependyma, this is notably a very bad factor for the future of the patient. So we are talking about some very bad cases. Instead, for low-grade glioma, we use, and in these cases, it's very, very rare that we use awake surgery for glioblastoma in the insula, because very, very frequently, due to the rapid growth, these patients are symptomatic. So they have already language disturbance or similar. So doing an awake surgery when the patient has 70 or 80% of error to the naming picture before surgery, it's completely useless to do awake surgery. So we dedicate awake surgery in patients they are good. They are no deficit. They answer very well to the neuropsychology test. But we do not operate all the patient awake surgery. As I told you, for me, it's very important the infiltration of the white matter in the dominant hemisphere, or even in the non-dominant hemisphere if the operculum is infiltrated. In that case, because you know that also in non-dominant, the operculum is implicated in praxis of language, so you have to stimulate. Anyway, as you know, there are some centers in the world that they operate every patient awake. But this is, in my opinion, this is just a matter of choice. This is not scientific evidence.
Yeah, thank you, Professor Speda. Two opinions here. One is that when you are I would like to know from the administrators, do we have another 2 or 3 minutes time? Or is our time over? Can we have 1 or 2 questions more?
Yes.
Okay, thank you. Now, when you are operating these lesions under electrophysiological monitoring, and you feel that there is a disturbance and you're entering in the little dangerous zone, but you are seeing the tumor in front of you.
Yeah. Do you stop or you do go?
Do you stop or you take a risk and exercise? Because our experience was what we have done many cases in that we take a risk and excise it. And our experience was what we feel, yes, immediately patient may have neurological deficits for 3 months, 6 weeks to 3 months. But we have seen all of them recovering over time. And the gross total resection rate is higher in these cases. Somehow I'm not, electrophysiological monitoring is good. It is good. But I'm a little skeptical when it comes to the deeper parts, when the tumor is looking at you and you see the changes on the monitor, it is in a big dilemma. But I would rather go ahead and excise it, even though there is a monitor change. What is your take on this?
Frankly, I think that the most problem of the insular surgery are tiny vessels. I mean, the strokes are the problem. Because if you even have, for example, aphasia postoperatively, it's very rare that the patient does not recover. But the point is, if you close perforators, this is a major problem. This is a major problem. So if I'm going through, for example, the posterior part of the insula, and I normally, when I'm in this delicate area, I use monopolar, okay, to search for corona radiata and internal capsule. And I use a step-by-step approach. So I start from 10 milliampere, then I go through, then 6 milliampere. When I get to 5 milliampere and I stimulate and I see that at 5 milliampere, there is responses in the corticospinal tract and there is tumor, I stop. Because at that point, it's not only the risk of the tumor, but also that you can eliminate some tiny vessels going to the capsule. So in this case, I really follow the stimulation. Otherwise, I just go for the tumor. I don't use the IOM if I do not believe it's useful. But again, in my experience, which is not 3,000 cases of insular tumor, but in my experience, the most severe problem has been vascular problem. Definitely.
I agree with you, 100%, no doubt about it. And that's a cause for long-term morbidity in these patients. Yeah. I think Professor Senna, wonderful presentation and wonderful sharing of your work and experience, which has made us quite rich. And you gave us an insight into the management of this, which is very, very important. That's what past, present, and future. Probably this thing will keep baffling us even in future with what we are going through in 21st century, 20th century. Probably ultimately the surgical skills, understanding the anatomy, physiology, and the microsurgical management of these lesions probably gives a good outcome to the patient. You have done, we are very thankful to you for your insight into the very complex problem, and you have made it very easy and understanding. Thank you very much,
for your question.
Thank you. Thank you.
There is a raise of hand by the audience. Dr. Shanawas, can you ask about your questions?
Thank you, Professor. It was an extraordinary talk. I have two questions. How do you assess the perioperative resectability? There are many armamentarium for this. So what are your combinations? And number two is, if it is low-grade glioma, what is the protocol for follow-up or oncological therapy or resurgery? Thank you.
Okay. As a surgical adjunct in the operating room, we always use echography, which unfortunately is not that reliable for the deep part or for perforators. Someone tried with contrast with microbubbles to see the perforators, but it is not as reliable as thought. We use fluorescein, so we use something to the higher grade gliomas. Unfortunately, in low grade, you do not have anything to better visualize other than echography. Otherwise, the intraoperative mapping is extremely important in this tumor. For the low-grade gliomas, we use, it depends, it depends about the extent of resection and of course the molecular setting of the tumor. So in cases where you have an oligodendroglioma with 1p 90q loss of heterozygosis, ID mutated, with a very good resection, with a patient who is 35, you can just follow up the patient. Normally, I prefer when you have some recurrence to reoperate. So I'm keen to reoperate the patient when it's good, when the patient has a good outcome, a patient has a good quality of life, the tumor recur. Of course, if the tumor is recurring inside the corticospinal tract, it's completely useless, but if it's feasible, why not? And today, as you know, the most important factor at the end is the molecular setting. So very, very, very frequently, opposite. It's very rare to have the triple positive. So a very good oligodendroglioma, it's not everyday surgery. Unfortunately, you see more astrocytomas, or you see more tumor with, for example, IDH1 wild type. In this case, we advise always radiotherapy. And another point is also the volume at the beginning. And this is another very important point because sometimes you have to leave behind some tiny pieces. So I would say 10%, 100% resection is not always possible. We are talking about infiltrating tumors. So we do follow up 3 months by 3 months in these cases. So a very, very strict follow-up.
One supplementary question, as Suresh Dugan.
I can't hear you.
Srinivas, I think you have muted yourself. Unmute, please unmute yourself.
Okay. Oh, yeah. Sir, as you are also here, any experience with perioperative ultrasonogram for the assessment of the resectability?
I didn't get you. Sorry.
No, intraoperative ultrasound.
Yeah.
Or intraoperative MRI.
No. We do not have MRI. We just have ultrasounds.
Ultrasound. Okay.
Oh.
Yes.
Okay. Thank you.
Thank you.
Yes, I think for the sake of time, and we should proceed to our next section by Professor Hudak. So Professor Hudak will be talking about the combined transarterial and transvenous embolization for AVMs. Professor Hudak, please share your screen.
Okay. Today I would like to speak about combined transarterial and transvenous approach for embolization of AVM. AVM is very difficult pathology for treatment of all type of method. Today we use 4 methods for AVM treatment. The first is Aruba. This is conservative or statistical treatment. And Winston Churchill said, I only believe the statistics that I falsified myself. Next treatment is neurosurgery. Problem with neurosurgery is only selected AVM can be treated. AVM excision often turns into the resection of less functional areas of the brain. I don't know what does it mean, less functional area in brain. Radiosurgery have problem. It's unpredictable proliferation of intima and unpredictable of prognosis of treatment. And last is this endovascular. Only 23 and 5% embolization of AVM possible of 100%. So with transarterial approach, we have big problem. In 1932, in 1957, Ghazi Yasargil compiled information from the literature of 500 AVM. Operative mortality for small AVM was 5%, and for moderate sizes AVMs it was 10%. It is a very good result of treatment many years ago. But if such good result of AVM treatment were in 1957, why do we offer conservative treatment today? What does conservative treatment of AVM, what quality of life awaits their patient? So this is small ant. This is small ant 2 millimeter size, and brain have 0.2 millimeter. It is and have excellent movement, survival, orientation, external sensory, proprioceptive sensory instincts, reproduction, regeneration, nutrition, and many, many other. What do you think there is less functional area in this 0.2 millimeter brain? I think no. Why do we think that the human brain have less functional areas? In 1999, I proposed and applied new method, combined transarterial and transvenous approach for the endovascular treatment of AVM. This is catheterization of AVM with from arterial route and from transvenous approach, and we used of intranidal arterial venous pressure monitoring. This is objective information about changing of pressure in nidus of AVM. And type of approach, this is transarterial, transvenous through the arterial route, transarterial, transvenous combined, and transvenous. Indication: diffuse non-catheterized microvessels, catheterization of the nidus impossible due to kinking of artery. Localization of AVM is in eloquent areas. Multisectoral AVMs. AVM vessels contain normal and abnormal feeders. Numbers of recidivs after AVM embolization. Why transvenous embolization? I would like to show one case is 22-year young woman with intracerebral hemorrhage, have this deep small AVM with small aneurysm. I perform transarterial embolization of AVM. And all okay, I close this AVM. You can see result of treatment of embolization with transarterial approach. This is lateral projection, and you can see vertebrobasilar system. AVM does not work, but 1 month control show recanalization of AVM. Combined transarterial transvenous approach, in these cases, I close malformed AVM transvenosely, and you can see control DSE immediately after operation, and possible see small remnant of AVM, but control angiography 3 months after operation show absolutely disappear of AVM. It is lateral projection. So problem or systematic recanalization of AVM after transarterial embolization. And I remember 14 procedure in treatment AVM. This is double VFITN meeting in South Africa in 2011. Professor Laurent Payrot show Bravo study with 11 European center, and you can see 100% of occlusion possible only in 23.5%. It's very small. What should we do with the rest 77 and 5% of AVM? Question: to one type of Spetzler-Martin grade, can this malformation be classified? Or maybe this small AVM size is 1.5 millimeter. It is possible only with very big magnification and non-standard projection of angiography. Is this young boy have big bleeding? What, for example, how to treat this type of AVM or not treat? In 1999, September 2, a new area began in the treatment of AVM. This is transvenous approach, but not only transvenous, greater combined transarterial, transvenous approach, CAVA approach. I show materials, the first material in Val d'Isère 2004, and many times in 2005, a treatment, a very difficult, deep AVM with combined transarterial transvenous approach. In China of WFITN 2007, this is novel strategy in the treatment of high-grade brain AVM, combined transarterial transvenous embolization by means of polyurethane-based new liquid polymer. I would like said about small of onyx, an embolic material. This is liquid polymer, and the inventor of this material is Varataki in 1990, a publicate of new liquid material for embolization of arterial venosus malformation. And I would say small about this material, but company right, onyx is not adhesive liquid embolic agent used for the pre-surgical embolization of brain arteriovenous malformation. But it's not all true. Onyx is adhesive material. And I don't know why we need of pre-surgical embolization, embolization of brain AVM. So this property became useful on in my new technique, which eliminated the need for supporting device, balloon, coil, double catheter. The use of supporting device makes the operation difficult and increase the risk of complication. Operation should be maximally simple and minimally dangerous. How does it work? This is schematic. I think the genius of the procedure lies in the simplicity. The volume of embolic agent in the catheter, in the microcatheter, is 0.17 millimeter. We push this quantity of onyx, and we wait of adhering of embolic material with microcatheter. After small injection, close of parent vessels. Adhesion of embolic material in the distal part of the catheter is 3-5 minutes. And after embolic material go return and close parent vessel and adhere with catheter. After it's retrograde and after complete occlusion of parent vessel, stay open of anterograde space. And after embolic material go anterogradely, and we close material. This is with transarterial approach. But what is problem with transarterial approach? Only transarterial embolization without transvenous may lead to occlusion of normal vessel and possible ischemic complication. What happened with transvenous approach? This same situation, but catheter stay in venous system, a draining venous system. Same situation, we push material is closed draining venous vein, and after go anterogradely, but pathological vein drains only pathological vessels, and we see occlusion only pathological vessels. This is type of AVM venous drainage. Technique of occlusion is dependent on zeotypes. The analysis of venous structure is extremely important before embolization. In 1989, I start work with new embolic material. This is HELP material, Hudak embolism liquid polymer. A new polyurethane-based liquid polymer agent with disappear of contrast material for endoscleral treatment of AVM. But not only material are important, but also the technique and strategy of the operation. How does it work in practice? AVM with angiographically provide nice saccular aneurysm and transvenous aneurysm. The cause of hemorrhage in the AVM was the stenosis of the distal drainage vein. This leads to increased pressure in the nidus and dilated veins. It's law of Bernoulli. There was intraoperative rupture during endovascular occlusion of the second aneurysm. You can see bleeding between operation. And I immediately occluded of the parent vessel with aneurysm by GDC. There were no any postoperative symptoms and the complication signs or leptomeningeal anastomosis. And this is control angiography after occlusion of parent vessel. Collateral filling of the AVM was impossible for catheterization. I used transvenous approach for treatment this malformation, and you can see catheterization of draining venous system. Microcatheter stay in draining vein, and this is super-selective venous angiography. And same with schematic, I show this of 0.17 milliliter embolic material. We push in catheter. Catheter adhered with embolic material and don't go retrogradely. Only close of draining venous system. But anterograd way stay is open, and after material go anterogradly, and I push embolic material in nidus of AVM. Retrograd AVM filling with HELP embolic material. The contrast agent disappeared slowly after the procedure, and you can see immediately after operation of embolic material stay in AVM. And 1 day later, embolic contrast material disappear from embolic polymer, from embolic material. And the AVM was completely occluded, and patient stay without symptoms. 48-year female, severe headache from 5 years. This is vertebral angiography. And this is carotid angiography. You can see many small feeder from middle cerebral artery and anterior cerebral artery. The first step is disjunction of fistula by means of GDC and HELP. Transvenous catheterization of draining veins, the second step. Third is transarterial catheterization of the posterior cerebral artery feeder. Fourth is transarterial embolization of AVM nidus by means of HELP. And second, transvenous occlusion of the draining vein and AVM by means of GDC and HELP. And you can see result 4 days after the last step. Malformation, it's not work. Not from vertebral basilar system and not work from carotid system. But what happened with carotid system? You can see normalization of pathological vessel, normalization of auto-regulation without any embolization of the feeders from middle cerebral artery. It is, for me, it is revolution of understanding of AVM. You can see carotid angiography 4 months after the last step. Malformation, it's not work, but not disappear. All capillary, it's normalized. CAVA steps, combined arteriovenous steps, procedure steps, transarterial catheterization of AVM feeders, transvenous catheterization of drain vein, double catheter procedure monitoring, transarterial embolization of fistulous rate, transvenous pressure control, occlusion embolization of AVM draining vein, control angiography, endotracheal narcosis controlled hypotension during 24-36 hours, control angiography 4-6 days later, and control angiography 3 months later. The next patient is 90-year female embolized in other hospital after 3 subarachnoid hemorrhage. We admitted here acutely after the 4 hemorrhage. This is malformation, it's perforated, it's impossible for transarterial catheterization, it's very difficult and dangerous. And you can see of catheterization of the draining vein of the AVM through the Rosenthal vein. And result after transvenous approach. Malformation is disappear and microcirculation and normalized. Young boy with intracerebral hemorrhage. Extremely small malformation. A supraselective angiography verifies the presence of the micro-AVM. Small feeder from the anterior cerebral artery cannot be catheterized. Lesion in lateral projection. Supraselective catheterization of the draining vein. Combined arteriovenous approach, and we close retrogradly. This is aneurysm and arteriovenous shunt. And postoperative control angiography. All normal vessel is stay. We don't have problem. We close only, this is fusiform, small 1 millimeter aneurysm. This is control angiography. About big malformation, 27-year-old female with intractable epilepsy previously underwent radiosurgery and numerous 7 embolization in other hospital. The AVM is supplied by many feeders. This is diffuse AVM in impossible catheterizing of all feeders. This is not standard projection. You can see this is morphology of this AVM. And this transarterial transvenous approach for embolization as AVM, and you can see result of treatment after 4 procedure. Pre- and post-operative, and lateral projection, preoperative and post-operative. All microcirculation is normalized. Now, small about physics of AVM. Anatomics often call it AVM arteriovenous aneurysms. Why? Malformation is its volume, and this is same with aneurysm. And I said about Bernoulli, it is physics who show what happened with difficult size of vessels. In increase of volume leads to an increase of pressure. Pressure in larger volume is much higher. Why malformation is bleeding? Occlusion of the draining vein drastically increases the pressure in the nidus. Pulsating or resonance amplifies this effect and possible rupture, hemorrhage. It's well known with high probability that a transvenous approach only leads to intracerebral bleeding. Thanks to transvenous approach, we not decide that stenosis of the draining vein close to sinus leads to AVM rupture. we observe it systematically. It often creates difficulties for the venous catheterization. Morphology confirms and explains this phenomenon. Entry of the drainage vein into the sinus has pachyony arachnoid granulation, which leads to stenosis of the distal part of the vein. The structure of several microchannels informed. I never propose only focal venous occlusion of the treatment of AVM. This is possible only in expansional cases. Focal venous occlusion was enough at the last step for the complete embolization of AVM. The parent vessel occlusion only prevented a risk of hemorrhage. The most effective way to prevent postoperative hemorrhage is the combined transarterial transvenous multi-stage fractional embolization of the AVM. Young patient with severe psychoorganic syndrome, hydrocephalus, status is rapidly worsening. You can see MRI and this AVM. What possible do with this type AVM? Many perforator impossible catheterized. So is this combined arteriovenous approach for treatment. You can see microcatheters in transvenous venously stay in AVM nidus draining vein, and microcatheter we put in one big perforator, but very danger. You can see second position in normal vessel in embolization in this situation. Very danger, but it is brainstem. And very important, put catheter very distally for success treatment, and we don't have complication after embolization this AVM. And now you can see a position of transvenous and transarterial catheter in AVM. And we embolize it of nidus transarterially and after transvenosely. And you can see result after embolization of this type of AVM, and patient status improved after operation. So this is pre and post-operative picture. Deep AVM of thalamic 15 years boy with Glasgow Coma Scale 7, intraventricular and intracerebral hemorrhage for 14 days ventilated and on ventricular drainage. Of feeders is choroidal and lenticulostrial artery, and you can see this is vertebrobasilar system, is posterior lateral and medial choroidal artery, and transvenous approach for treatment this type of AVM. You can see transvenous we put of GDC for stop of retrograde flow. And angiography after embolization of nidus via one lenticular striate artery and the thalamostriate vein beneath of coil and hell. Remnants of nidus still feeling at stasis in draining vein. It's immediately after operation. But what happens 3 months later? Malformation is disappear, and not only disappear, malformation is normalized of microcirculation. You can see pre and post-operative result. And I don't embolize it of from vertebrobasilar system, this pathology, and you can see malformation is normalized. Not normal vessel, it is normalized. This is young boy with epilepsy. 7 months later after transvenous approach, don't have symptoms. Deep AVM of dominant hemisphere and very eloquent area, and you can see result of treatment. From AVM from pericallosal artery. Pericallosal artery is very difficult and very dangerous for transarterial embolization. And this is 23-year female with subarachnoid hemorrhage. What possible do in this situation is different phases of contrast filling. This procedure of catheterization of venous system, and finally result of treatment, right and left side of carotid artery, and non-standard protection without embolization of all feeders. So hemorrhagic complication, what is possible? It's possible intraoperative, perioperative, and postoperative complication. Intraoperative is a guide wire microcatheter vessel perforation, embolic material extravasation, vascular dissection. Preoperative, this rapid hemodynamic changing, must danger unpredictable. And sharp increase of blood pressure, and postoperative intraneedral aneurysm rupture, epileptic seizure. And ischemic complication, possible arterial venous retrograde embolization, transnidal embolic material spreading and the normal artery system, catheter rupture during injection of embolic material, and embolization of normal vein. And I would like to say about quintessence of my 25 years of experience of treatment with transvenous and transarterial approach. Carefully analyze the venous system before embolization. Use the intermediate catheter for transvenous approach. Don't start embolization of AVM transvenously. Start AVM embolization with AV shunt. Do not allow the embolizing material to occlude the draining vein at the beginning of the procedure. Don't embolize high-grade AVM in one procedure. If a transarterial approach is not possible, embolize the venous system fractionally. Allow time for hemodynamic adaptation. Begin embolization from a less eloquent area. Stop embolization if you feel the resistance during injection. The treatment of AVM technically should be simple. Don't use unnecessary device. Don't do unnecessary manipulation. Don't push an embolic agent quickly. The venous wall are much thinner than the arterial wall. You have to embolize if effortlessly to avoid perforation. Learn to work filigree. Ask yourself during the whole procedure what I do. Great discovery that has changed my understanding about the nature of AVM 25 years ago. The vascular system of the brain is completely normalized after focal venous occlusion of AVM without extensive embolization. Transarterial partial embolization of the fistulas and nidus is used to produce the risk of the hemorrhage. The near future today, combined transarterial transvenous approach, CAVA, new liquid embolic agent with disappearing contrast material, new embolization technique to prevent complication, improved device, understanding of the pathology, intranidal arteriovenous pressure monitoring, and 3D printing. And conclusion of angiographic definition of the nidus of the AVM may be misleading. strategy of transarterial embolization and also the other treatment modalities need basic reconsideration. Vessels originally visualized, nidal and anomalous mustn't be always occluded, resected, or irradiated because they are capable of regeneration and normalization. My aim was to develop a method for the successful treatment of all grades of AVM without exception, and not just selective cases, which are approximately 23-27%. Be careful that I have said is not yet enough for successful treatment of all AVM. Thank you very much.
Thank you. Thank you so much, Professor Budak. So shall I invite any comments from Professor Tugani?
Yeah, I think Professor Budak is the one. Thank you very much for the excellent information and newer technique of managing this very formidable, complex problems as neurosurgeons and neuroradiologists are called upon to treat in our day-to-day work. Thank you very much. It was indeed enlightening, a newer procedure, because I'm a surgeon, I'm a neurosurgeon.
I'm same. I'm same.
Okay. And my philosophy or my belief is that AVMs are neurosurgical problems. I believe excise them completely, whatever. If they have bled anywhere, excision is the only answer, except maybe hypothalamus, brainstem, and deeper thalamic locations. I would take your help to treat these things better. But I know as the time is going on, things are changing up very fast, and you showed wonderful obliteration of these lesions. I have a few what do you call questions. If I may be asking you, is it okay, Professor Budak? Yes. See, when you push the contrast with the agent in thrombotic agent into the vein, the pressure from the arterial side to venous side is very high. Will it flow into the venous system and get into the arterial system, like as what you have shown in these AV malformations? Number two, the wall structure of veins, as you rightly mentioned, is not as strong as artery. When you inject, you need to inject with the force or the calculated strength. Does it affect the walls of the veins and leading to any premature rupture of these AVMs? And what's the rate of obliteration, percentage of obliteration of these AVMs when we use transvenous route as compared to arterial routes? And does it lead to incomplete obliteration of the arterial system? Because when there are many small feeders, micro feeders from the arterial side, which are failed to the material fails to enter these vessels, over time, are there any occasions for the regrowth of the AVM side of the AVM or much away from the nidus? These are the few what you call questions are in my mind. And the deeper venous system, like intraventricular veins or deeper veins, they are very delicate as compared to the other veins. How does it help going into in these deeper parts of the AVMs with your expert opinion? and enlightenment. I would just wanted to add.
This is not simple. And you know, it is way.
Yeah, exactly.
I have a 36-year experience with treatment vascular neuropathology. And, you know, yes, this is beautiful. And for me, it's big revolution of transvenous approach, but we have problem. I'm neurosurgeon, and I very good know about coagulation in one vein, possible bleeding and possible of infarct, of venous infarct. But interesting, in AVM situation, it's not happen. Why? But this is pathology. In AVM situation, venous system have many bridging of collateral system. And interesting, after transvenous approach, and so my aim, it's not occluding all nidus, but I show of big areas of nidus normalized after transvenous approach. Why this happen? But arteriovenous malformation is not arteriovenous malformations. It's capillary and venous pathology. And aim for treatment, it's not artery. But why I embolize it of transarterially? Only transvenous approach, it's very dangerous. And I don't propose this for the starting doctors. It is very difficult pathology, and this need many big experience for treatment. But interesting, I happy after my first cases in 1999, treated successfully without bleeding, and after I see of bleeding after only transvenous approach. And I think many years ago, I think about this fantastic method. It's simple. It's not very dangerous for many small of perforators. And after bleedings, after my operation, I stop this and I analyze it, what happened. And we know of occlusion of vein in normal brain and possible bleeding. We see this. Who is a vascular surgeon is very good know about this. So it is need very big experience for treatment and the analysis of not only arterial phases of angiography. It's need analysis of all venous system. It's not simple, and I said about this, but this is revolution. It's yes, it's true, but for treated of difficult AVM need very big experience. I think this, and I know yes, venous wall it's not same with arterial wall, and I said about this is it's need very filigrane job, very filigrane catheterization for this. So it's my opinion about this.
What's the rate of regrowth or recurrence of this when you do the transvenous approach to these lesions?
Yes, I remember you asked, so venous system have retrograde flow, yes? What is possible of including in retrograde flow? This happen of adhesive onyx is adhesive of embolic material, and the first injection very slowly, and is adhered for catheter end, and after stay and after I do small ball close of venous, and after this is embolic material don't move, but of way anterograde it stay open, and after occlusion of proximal part of draining vein, embolic material go anterograde in nidus. This is technique. So many doctors don't understand this impossible retrograde
That's
pushing
right.
of
Yes.
embolic material. It's crazy.
Yes.
It's not, it's
True.
impossible.
True. Okay.
Sorry, Professor, can I ask a question about your concept of embolization? So, I would like to ask about in your experience in treating complex AVM. Have you ever how often do you consider stage embolization for these complex AVM? So,
how many patients? Yeah, but you know, I have
I
many.
mean, I mean, sorry, I mean, stage embolization. So perform the embolization in stage to treat the AVM, and which usually at what stage would you consider using the combined method as described by your technique, if you have to consider a stage embolization?
So I think it's a treatment of AVM need experience. It is impossible said about, but we know many type of AVM. It is deep AVM, it is dural AVM, extracranial, intra. So many time of fistulas, of diffuse. So many malformation with aneurysm, intranidal aneurysm, malformation with extranidal. So it's all need of analysis, very good analysis, and it's impossible start after my lecture. The next day start embolizing of AVM. It's not good. It's need. I invite doctors, young doctors in my clinic, and possible show, and it's need not months, it's need year for understanding. And I think it is future, but you know, now it's all radiosurgery is this problem for treatment of deep AVM, for big AVM. Neurosurgery is very good for convexital AVM, yes, but deep AVM we don't propose for treatment of neurosurgical. And my very good friend, it's Juha Hernesniemi, is his best surgeons, vascular surgeons, and we many discuss with in this pathology, in vascular AVM pathology. And after Juha said me, Stefan, you know, I think endovascular is future. This not so possible treated convexital small AVM of brain without problem, without symptom. But I said it's usually of removing what of AVM from brain. This is resection. And this is big trauma, and I start my presentation so in brain don't have of not eloquent areas. So all brain is very important. It's my opinion.
Thank you so much for your comment. I think it's very important comment to the young neurosurgeons when they want to learn the concept of embolization of the AVM, and it's very difficult situation for us. And of course, with your lectures, it will increase our understanding with this. And may I ask, is there any comments from the floor? I do not see any comments or hands raised from the audience.
Okay.
New, you have any comment?
Yeah, thanks, Prof, for a very nice presentation. May I ask you, do you think that the etiology of AVM and also AV fistula, there's more evidence to show that there is some venous sinus problem floor problem. Do you think that by doing a venous approach, you actually have secondary gain by opening up all the sinuses and actually help in successfully treating your AVM as how people treat AVF, Professor? Thank you.
Thank you for question. So I think it's we don't know all about etiology of AVM. We see it's open AVM, for example, fistulas, dural fistula. Patient don't have never symptom, and one night it's wake up and have of chemosis, and we don't know what happened. But I see many malformation without of extracranial and dural parts. So possible see it's mix of intracranial, dural, and other. And after embolization, open of dural part of AVM. Interesting, my 36 year of experience of vascular surgery, I show patient who I treated in 2004, so it's now it's 20 years ago, and after transvenous and after good result of treatment, not happen of recanalization of AVM. I think AVM is not malignization, it is tumor. But we see situation after radiosurgery start malignization of AVM, and after 3 tumor we see of tumor after radiosurgery. But I think normalization of microcirculation after transvenous approach, this is shows maybe this is of genetic vascular pathology. But now we don't know what is etiology of AVM. And I think it's a big revolution of, but you know, what does me start of treatment AVM transvenously? For me, it is happening first involved in 1999 in Hungary, in Pécs University. I do the first transvenous approach. Why? But we have many problems with treatment AVM. So 14 procedure and no result. Bleeding between operation. I show of WFITN in South Africa, treatment or successful treatment of AVM, only 23%. And what happened with 78%, 77%. So we have big problem, and now neurosurgery treatment of AVM don't improve. I remember of Ernest Niemi, of Dazi Yassar-Gil, is all treatment approach stay without changing. So I don't have, only in endovascular treatment I see of progress and open new possibility of treatment of this pathology.
Yeah, maybe in the future, I think we probably need to measure the
I have very good contact with doctors from Japan, from Kobe and from Sendai. We have many year contact, and we work with this. And I think maybe in the future, but only one is need very good experience and long time. It's impossible. It's not stand from carotid artery. So it's not thrombectomy. This is need very big experience.
Thank you, Professor.
Thank you.
Professor, can I ask one last question, Professor Budak? Now, in your experience-wise, when the AVM is referred to you by the surgery, you do the endovascular transvenous embolization. Does it make any difference in the surgical procedure Rather, does it make the surgery better than what it was done trans-arterial comparatively? Because already the venous channels are...
What is problem with neurosurgery? This is very selective malformation. Neurosurgeons select malformation for treatment. And so it's good for convexital, from frontal, not eloquent areas. I said it, but what happened with 77% of IVM who don't treat it? And okay, malformation, it's don't have bleeding. Yes, patient have of epileptic seizure problems, but it's possible treated with anti-epileptic drugs. But we don't know treatment of IVM. Many clinic don't know treated. So possible in big European clinic, we asked how many patients with IVM operate per 1 year, and this is 25, 30 per 1 year. It's very small quantitative for understanding. And why I start work, but I'm neurosurgist. Why I start endovascular treated IVM, but I see perspective of future for treatment, not operable IVMs. This is very important. It's not, so I think it's, I know many neurosurgeons who fantastic operate, very good technique, very, very good. But I said this is only selective cases.
Thank you. Thank you.
Professor Sprenger, any comment?
Yeah, just a very easy question. What do you think about the micro AVMs, I mean, very tiny AVMs that seem to bleed very much? Because very frequently we find micro.
Size of IVM don't depend from bleeding.
Okay.
Possible very, very small IVM. I show IVM, this is arteriovenous. I don't understand what is this. This is arteriovenous shunt, and this is small aneurysm is just after bleeding we see. So it is small aneurysm as a bleeding aneurysm. But interesting, we don't know all about this pathology.
But do you think that a small, tiny micro IVMs can develop into a big IVM?
No.
Okay.
It's absolutely undependent. You know, I see many, and we do control angio, many follow-up, many time, and I don't see big changing of IVM. Without treatment, so not treated IVM. It stay, size is not changing. It is not depend. It is depend from genetic, I think.
Okay, thank you.
Understand. So if there's no further comments from the floor, then I would like to thank you all of the speakers here. So and come to the end of these webinars. So on behalf of the Education Committee of the ACNS and the President Professor Yoko Kato, I would like to thank both the speakers today, Professor István Hudak, and also Professor Antoni Sprenger, as well as the chair, Professor Dugani, for the time and the support for the ACNS webinars. Also, a special thanks to Professor Xu Bin for broadcasting this webinar on the WeChat channel. Today, we have around 750 views on the WeChat channel. And special thanks to my co-host, Dr. Liu, for joining me today. So again, thank you very much for all of you to join me today, and it's bye-bye to us. And I hope all of you have a good day onwards. Thank you so much.